Dear doctors, good afternoon. Hoping you and your families are safe and well. On behalf of Survey, welcome to the webinar of Comprehensive Care in ALL Management to address next level of care in Saudi Arabia, in collaboration with Saudi Society for Blood Disorders. Let me please first introduce our chairman today, Dr. Feras Alfraih. Dr. Feras is a president of Saudi Society for Blood Disorders. He is the director of Alternate Stem Cell Donor Program and consultant in adult hematology, hematopoietic stem cell transplantation at King Faisal Hospital and Research Center. Dr. Alfraih gained his medical degree from College of Medicine at King Saud University. Later, he joined the Princess Margaret Cancer Center in Toronto, where he completed training in adult hematology and bone marrow transplant. Dr. Alfraih is a member of several national and international organizations, including American Society of Bone Marrow Transplant, Canadian Bone Marrow Transplant Group, World Marrow Donor Association. He is also journal reviewer of Journal of Annals of Saudi Medicine, Journal of Hematology, Oncology and Stem Cell Therapy, and the Journal of Applied Hematology. Dr. Feras, the floor is yours now.
So good afternoon, everyone. I would like to welcome you today to this webinar, which is done in collaboration with Survey. So in this webinar today, we are lucky to have several renowned speakers from the country that will join us today to share their experience in how to provide comprehensive care for acute lymphoblastic leukemia patients. We will be having Dr. Amr Hanbali, who's an adult hematology consultant in King Faisal Specialist Hospital, and he's one of the ALL specialized team in our institution. Dr. Amr will talk about the use of pediatric inspired protocol in AYA and ALL, specifically about KFSH experience. The second talk, there will be a slight change in the program. Second talk will be given by Dr. Imran Tailor. He will talk about MRD in ALL. The third talk will be given by Dr. Absi about managing CNS disease. And then we'll have a 15-minute for Q&A, followed by practical approaches presented by Dr. Riad Elfakih. I would ask attendees kindly to write your questions in the questions tab. Without any further delay, I would like to invite Dr. Amr Hanbali to start the first talk. Dr. Amr.
Okay, Assalamu alaikum. I would like to thank Dr. Feras and the organizing committee for inviting me to talk about one of my favorite topics, which is the treatment of acute lymphoblastic leukemia in adolescents and young adults, which we call the AYA population. I have no disclosures to declare. ALL, as we know, is a hematological malignancy related to abnormal proliferation and differentiation of a clonal population of lymphoid cells. It's the most common hematological malignancy in children, and ALL is considered a challenging disease to treat in adult population. We have historic cure rates in adults of 20 to 40%. Signs and symptoms of ALL can be explained by the pathophysiology of the disease with the suppression of the normal hematopoiesis, infiltration and colonization of the lymphoid organs, and the release of the inflammatory markers. While treating ALL is considered a successful story in pediatrics with 5-year event-free survival of almost 85%, adults with ALL have a much poorer prognosis with 3-year overall survival of less than 45% when treating patients with adult-oriented programs. The worst prognosis in adults could be related to worse cytogenetics with higher relapse rate, difficulty in eradicating MRD, and poor tolerance to intensive chemotherapy. Even worse for patients with relapsed disease, especially for patients who relapse early while on chemotherapy or with remission duration of less than 24 months, their long-term survival is dismal, with 5-year overall survival of less than 10%, even in patients undergoing a stem cell transplant. Of course, with the introduction of immunological therapies nowadays, survival has improved. ALL is a disease of pediatrics. Median age at diagnosis is 15 years. As seen in the graph, AYA population represent a major part of the disease age distribution, and that's why attention to this especially group is important in improving the disease outcome. Looking at survival curve of patients with ALL, we see improvement in survival, especially in the past 10 years, and that's mainly related to improvement in the treatment modalities available for the disease. These two curves show the cure rate and overall survival of ALL patients according to age. If we look at young patients aged 1 to 4, we see the outcome is excellent with long-term disease-free survival of more than 90%. Of course, we know that disease in infant has a very poor prognosis. But the older the patient, the worse the outcome, and in particular, patients more than 30 years of age carry worse prognosis. And that's why it's important to be able to move the field forward and have better outcome with new tools. Now, the listed risk factors here in this slide are considered conventional prognostic factors, but the better understanding of the value of minimal residual disease in ALL made us realize that MRD now is considered the most powerful prognostic risk factor, and it overrides all other factors mentioned in this slide. Maybe one exception is carrying MLL gene rearrangement. The literature is controversial in that area if MRD overrides this bad cytogenetic or bad prognostic factor. In our data, patients with MLL have high relapse rate even when they have a negative MRD, but we talk about a very small sample size. Now let's start with the way adult ALL patients have been treated using the adult programs. So induction chemotherapy is made of combination of chemotherapeutic agents. There are many published induction regimens, and none have been directly compared in randomized trials, which makes it difficult to identify the best regimen out of all published regimens. Typical chemotherapeutic agents in induction regimens include vincristine, corticosteroids, anthracycline, along with CNS prophylaxis. Such combination can induce complete remission of around 80 to 85% of patients with ALL. Other agents that can incorporate in the induction regimen include cyclophosphamide, cetorabine, MTX, 6MP, and asparaginase. Such agents usually don't improve CR rate, but can help achieving CR faster, and that can translate into prolongation of remission. And this slide shows you some of the non-adult ALL regimens among many other published regimens. The key feature of adult ALL regimen is to proceed with allogeneic stem cell transplant in first remission in most cases. And as mentioned earlier, this approach will produce long-term disease-free survival and overall survival of less than 45%, which is unsatisfactory by all means. So let's discuss now treatment of ALL in AYA population. Now, AYA has different definitions. NCI define it as ages between 15 and 39, while SEER and COG define it as ages between 15 and 29. Most importantly is to recognize that such age group differ from children as well as from adult patients in terms of disease biology, psychosocial challenges, survival, and in other important aspects. This table shows some of the biological features of AYA population which make them different from pediatric and make them a unique group. As shown, although their age is close to pediatrics, disease features are different from pediatric in terms of higher incidence of worse cytogenetic features, higher frequency of molecular mutations that define, which is known now as Philadelphia-like ALL, which carries worse prognosis with higher MRD burden after induction. Also higher incidence of early T precursor ALL, which carries poor prognosis in general. And ultimately, this group's tolerance to intensive chemotherapy is poorer than children. The main difference between adult and pediatric regimens include, in adults, regimens usually depend on intensive use of myelosuppressive agents to induce remission, followed by allogeneic stem cell transplant in first remission. Pediatric protocols use less intensive myelosuppressive regimens alone, with early and frequent CNS prophylaxis and prolonged maintenance phase, with only highly selected cases to undergo allogeneic stem cell transplant. Studies started to evaluate the use of pediatric regimens in AYA population, And this is one of the early retrospective studies which compared a pediatric regimen with adult regimen in patients ages 15 to 20 years. Pediatric regimen had more steroids, more vinca alkaloids, and more asparaginase, and had less interruptions between CR and post-remission therapy. This French study showed superiority of pediatric regimens in terms of CR rate and 5-year event-free survival, with multivariate analysis confirming the independent influence of the protocol on outcome. This is another retrospective study that made similar comparison in patients ages between 16 and 20 years. As shown in the graph, pediatric regimens, which is the CCG, in this trial was superior to CALGB adult regimen in terms of event-free survival, overall survival, and CNS relapse rate. This table shows summary of multiple trials that compared pediatric protocols to adult protocols in IA population, and there is consensus in superiority of pediatric protocols in such population. Now, to assess the tolerability and feasibility of using pediatric regimen in IA population, the US intergroup designed the largest prospective study in patients ages between 16 and 39 who were treated with the COG pediatric regimen. The results of the study was similar to what was published before, with 2 years event-free survival of 66% and overall survival of 78%. Important to note from this study is that toxicities were manageable, with low treatment-related mortality of 3%. Another example is this meta-analysis that looked at 11 studies that compared pediatric protocols to adult protocols in IA population, and results showed higher CR rate, higher event-free survival, lower relapse rate, and lower all-cause mortality with similar non-relapse mortality. Now, let's just take a quick look at some specific pediatric-inspired protocols that are used by adult hematologists in treating ALL in IA population. This is the study by the French GRAL group, which evaluated 215 patients ages between 15 and 60 years of age with ALL. Patients were treated with pediatric-inspired protocol. CR rate was around 94%, 3-year event-free survival of 55%, and overall survival of 60%. Looking specifically at patients older than 45 years of age, the study showed higher chemotherapy-related deaths and higher mortality in first remission, which confirms the concern of higher toxicity in older population. Now, the Dutch Hoven group did a similar analysis using pediatric-inspired protocol of 54 patients with ALL up to age of 40 with average age of 26. The design of the study included use of allogenic stem cell transplant as intensification phase, and results were similar with event-free survival of 66% and overall survival of 72%. This table summarizes other published pediatric-inspired protocols in ALL-IA patients with similar results to what we mentioned before. The most recent prospective trial to evaluate pediatric-inspired protocols in IA population was the CALGB 10402. It looked at 318 patients with median age of 24. Results were similar to what was published before, with event-free survival close to 60% and overall survival of 73%. Treatment-related mortality was low as at 3%. This study highlighted important risk factors for worse outcome, including obesity and presence of Philadelphia-like gene expression signatures. It's important to note that outcome of ALL in IA patients is influenced by the center treating patients. Outcome is better if treatment is administered at a university or NCI-sponsored cancer center with high experience in ALL management. For example, MD Anderson showed results of adult regimen hyper-CVAD comparable to pediatric regimen. Just to note that such results might not replicate in community hospitals or centers not experienced in ALL management. Now, just a quick few words on minimal residual disease, but we will hear more details from Dr. Tailor's presentation today. MRD is defined as any approach used to detect residual tumor cells beyond the sensitivity level of cytomorphology. These methods can include detection of the leukemic phenotype by flow cytometry or detection of fusion transcripts or antigen receptor rearrangement by PCR or NGS. And as mentioned before, MRD is accepted now as the strongest independent prognostic factor in ALL. There are different types of MRD depending on the sensitivity of the method of detection, but a truly negative MRD currently is beyond the available methods, and for that, the best term to be used right now is measurable residual disease instead of minimal residual disease. Timing of MRD detection is important. Early clearance of MRD, like after induction, can predict good prognosis and very low risk of relapse, while persisting MRD after consolidation phase is usually indicative of poor prognosis, and chemotherapy alone will not be enough. So what's the role of allogenic stem cell transplantation in first remission in AYA patients undergoing pediatric inspired protocols? One trial to answer this question was the GRAL 2003-2005 trial, which evaluated 522 patients ages between 15 and 55 who have higher risk ALL. Almost half of these patients underwent allogenic stem cell transplant in CR1. The results showed no difference in relapse-free survival and overall survival. Maybe the only one exception was patients who carry IKZF1 deletion who did benefit from stem cell transplant. This is another study that showed the benefit of stem cell transplant in patients with positive MRD. Important to note here is that the outcome was equivalent between patients with good MRD responders who did get transplant and with poor MRD responders who did get the transplant. International bone marrow transplant registry study showed better results with pediatric inspired protocol alone versus transplant in CR1, and that's likely because of the transplant-related mortality. This meta-analysis answered another important question. Is transplant enough in improving prognosis of poor MRD responders? It evaluated 21 studies regarding the prognostic effect of MRD prior to transplant and showed patients who underwent transplant while they have positive MRD had higher relapse rate and less relapse-free survival. So what should we do then? The best outcome will be if we can eradicate MRD prior to stem cell transplant. Blinatumomab, which is a specific T-cell engager antibody, is FDA approved in B-cell ALL with positive MRD based on results of the BLAST study, which showed improved overall survival in patients who turned into MRD negative with Blina. And Blina achieved MRD negativity in 80% of patients with MRD positive. So in conclusion, allogenic stem cell transplant in CR1 should be only considered in specific situations like MLL arrangement, hypodiploidy, and Philadelphia-like ALL, and of course, as we discussed in MRD positive patients. All other patients should continue on chemotherapy alone. For patients with MRD positive disease, it's best to try to eradicate MRD prior to stem cell transplant, and one option is to use blinatumomab in B-cell ALL. Just a special few important notes in ALL treatment. There has been debate in literature regarding what's the best steroid formula to use. This meta-analysis showed that dexamethasone is superior to prednisone in terms of disease relapse, including CNS relapse, but this is balanced with increased mortality during induction. Therefore, it's best to use prednisone during induction and dexamethasone in phases thereafter. Of course, it's well established now that rituximab adds benefit to chemotherapy regimens in CD20 positive ALL patients and should be part of any chemotherapy protocol used. One important note is the need to escalate the dose of 6-MP and methotrexate during the prolonged maintenance phase to induce adequate myelosuppression, since this translates into better event-free survival. Also, one has to make sure of patients' compliance, since this phase is long and entirely outpatient with infrequent visits to the clinic. It's vital also to make sure of continuous exposure rather than just frequent interruptions to decrease the risk of relapse. And for patients with severe myelosuppression that needs drug interruptions, think of pharmacogenomic like the TPMT deficiency. We should not forget the long-term complications that can affect the patients, including CNS, endocrine, cardiac, and risk of second malignancies. Also, osteoporosis and osteonecrosis along with infertility issues. Now, in the last few minutes, I just going to talk to you briefly about the protocol we use in King Faisal Specialist Hospital in Riyadh. So our protocol is adapted with modifications from King Faisal Pediatric ALL protocol, which is called the PA-ALL-08, and this protocol is adapted from international protocol CCG 1900. We called our protocol IA-15 because it was established in 2015. The key features of our protocol include use of asparaginase, which was not part of the previous adult protocol we used to use in King Faisal. Use of methotrexate in forms of Capezi escalating strategy or high-dose methotrexate in T-cell ALL. Intensification of CNS prophylaxis with total of 24 to 29 intrathecals during the whole course of treatment. We used to do prophylactic cranial irradiation for patients with very high risk disease, but we stopped doing it right now, and the cranial irradiation is restricted to patients with positive CNS disease. And as we mentioned before, we use prednisone during induction and dexamethasone in the post-induction phase, and we use a stem cell transplant in selected indications. We include both the B and T cell ALL and LBL, lymphoblastic lymphoma, in our protocol, but we exclude Philadelphia positive ALL and biphenotypic leukemia, as these have their own separate protocols. Our protocol is MRD dependent. We check MRD twice, once after induction, and we use it only for prognostication, but it does not change the schema of the protocol, while another one will be checked after consolidation, with patients with positive MRD go to allogenic stem cell transplant, while negative results will make patients continue on chemotherapy. First analysis of the first 40 patients of the protocol showed 5-year overall survival of 75%, 5-year disease-free survival of 75%, and event-free survival of 60%. Our results were comparable to other international groups as seen in this table, and currently we are preparing to report a total of 80 cases who are being treated on this protocol. Thank you for listening, and stay safe.
Thank you, Amr, for an excellent talk. I would remind the audience to write their questions in the questions tab. We will move to our next speaker. Dr. Imran Tailor is an adult hematology consultant in King Fahd Medical City with several applications and extensive experience. He will talk about MRD. Dr. Imran, the floor is yours.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Wassalatu ala Rasulil Kareem. First of all, I would like to thank the organizers, Saudi Society of Blood Disorders and Surveyor, for the kind invitation to this fantastic symposium on acute lymphoblastic leukemia. Today, I've been asked to talk on optimization of MRD in the diagnosis and management of acute lymphoblastic leukemia. So I have no disclosures to make. So acute lymphoblastic leukemia, 3/4 of the cases are precursor B cell type. As Dr. Hanbali mentioned, the prognosis remains poor in adults with 3-year disease-free survival ranging around 40%. The problem with first salvage or second salvage is the poor CR rates that precludes our ability to bridge for the potentially curative allogenic stem cell transplant. So you've seen the slide before. On the left-hand side, excellent results among children reaching cure rates up to 90%, whereas adults over 30 years of age, the outcomes are really poor. These are the traditional risk factors we don't have to go through. The single most prognostic indicator of outcomes in ALL is MRD, minimal residual disease, or what we call measurable residual disease now. Presence of more than 10⁻⁴ or greater than 0.01%, which means presence of more than one leukemic cell out of 10,000 white cells would constitute positive MRD. So if you look at this data from the MRC UCAL trial, which looked at more than 2,000 patients, 2,900 patients, the outcomes of patients with relapsed ALL are dismal. The 5-year survival is just around 7%. So is the data from the LALA 94. So what it means is we need to get our best therapeutic strategy at the first go. So the aim with the frontline treatment is to get MRD negativity so that we enhance the cure rate. With the advances in stem cell transplant and immunotherapies, the results are better, but still they are not great. So Amr has beautifully gone through this pediatric versus adult regimens. So if you look at the right-hand side, different randomized controlled trials from different groups, American, British, German, Italian, all showing the survival rates of the pediatric protocols reaching up to 80%, whereas adult protocol around 40 to 50%. So the pediatric regimens, I think I should emphasize again, more intensive use of corticosteroids, vincristine, asparaginase or pegylated asparaginase we use these days, more methotrexate-based, CNS-based therapy, and longer maintenance for boys up to 3 years, as there is higher risk among boys. And they emphasize on timely administration and typically include MRD assessment. And pediatric hematologists have been doing this for the last 2 decades, but fortunately we adults have picked up in the last 10 years. We have also been doing more and more MRD even in other diseases now. So if you look at this data from CALGB, the pediatric regimen used for older adolescents and young adults, the event-free survival is 78 months, whereas the historical control event-free survival was only 30 months. So adolescents and young adults, or IR group, are doing well with the pediatric regimens, and several other studies were mentioned, shown by Amr in the previous slides. So I'll be going through measurable or minimal residual disease in the next few slides. What is it and how we do it, and what measures we have or what interventions we can to address this issue. So I would prefer to call it measurable because minimal sometimes minimizes its importance. So what is it exactly? So when you give chemotherapy to a patient, we expect the chemo to eradicate all the cancer cells. But unfortunately, it doesn't happen in reality. There is some residual disease persistent that can, if not addressed, grow further and cause relapse. So now with the newer technologies, at every time point, we can measure exactly this minimal residual or measurable residual disease. And the factors which push MRD are poor cytogenetics, niche effects, or immune evasion, and so on. And this is a study, meta-analysis published looking at both impact of MRD in pediatric ALL outcomes as well as adult ALL outcomes. So in pediatric ALL, 20 studies, more than 11,000 patients, presence of MRD has significantly poor outcomes with a hazard ratio of 0.23. In adults, 16 studies, over 2,000 patients, again, MRD, presence of MRD has a poor impact on the outcome with a hazard ratio of 0.28. And for overall survival for both the groups, hazard ratio is 0.28. So again, if you look at the individual studies, every single study that was looked at in this study, in this meta-analysis, showed presence of MRD has a poor impact on the outcome, irrespective of the method you use, either flow cytometry or molecular method. And this another study looking at the outcomes among adult patients who have persistent MRD. If they have MRD, the 5-year survival is 42% compared to 80% those who are MRD negative. And if you exclude stem cell transplant, the 5-year survival even reduces to 32%. And again, this study that looked at the impact of MRD, again, on adolescents and young adults, they looked at MRD at different time points, day 24 at the end of induction, at the end of consolidation, week 22, and again, pre-maintenance. And in all these 3 groups, you can see the disease-free survival is significantly higher if you are MRD negative. For example, at consolidation, 65 versus 11%. Again, these are the 4 different prospective trials from different groups done among adults, looking at the impact of MRD and the outcome. The graph A is from Italian, again showing impact of MRD. So the German on graph B, 5-year survival is 35% versus 74%, almost double. And the graph D, again, it's from Spanish group, showing presence of MRD more than 0.1% at the end of induction as poor outcome, as improved by transplant. If you look at the graph C, here again from the PETHEMA group, the MRD was more than 0.05% at the end of consolidation, or blast more than 10% on day 14. They went straight to allo transplant. Rest continued chemo. So the 5-year survival is 55% with the chemo, but with allo, 5-year survival is 32%. So what I'm trying to say here is poor MRD, even though allogenic is curative, has curative potential, it does not overcome all the bad impact of MRD. So again, this data looking at the impact of MRD pre-transplant and post-transplant. So if somebody goes to transplant with the MRD more than 0.01%, their 5-year event-free survival is going to be 30% compared to those who are negative 77%. So is the relapse 11% versus 61%. So now come briefly on methods of quantifying MRD. So we have flow cytometry that's easily available, and almost all centers who treat leukemia have access to. So what exactly we do in flow cytometry? So you take a sample and you have lasers and antibodies. You look at the events. You can study the cell based on its size and its complexity of the cytoplasm, different antigens it expresses on its surface or within inside. So these antibodies bind to these antigens, and that get tagged to the fluorochromes, which gives you the color flow cytometry. You call it 8-color, 10-color, depending on the antibodies panels you have. You can have up to 20 color flow cytometry. So to get a sensitivity of, so normally in diagnostic flow cytometry, you need 20,000 events to know how many cells are CD20 positive or CD3 positive, and so on. But to get into MRD, you need to at least have 200,000 events to get a sensitivity of 10⁻⁴. Or if you want to get a sensitivity of 10⁻�6, you probably have to analyze 2 million events. So this is to some extent operator dependent, and also what quality of sample you get. So I advise everyone to get the first 2 mils pull for flow cytometry. Otherwise, you'll be diluting it, and you might be underestimating. So you need a fresh sample. So it's relatively lower sensitive, but with multicolor, you can increase the sensitivity. Coming to the MRD quantification by PCR, the sensitivity goes up to 10⁻⁴ to 10⁻⁵. So you have 2 different types here. One, you can do quantitative PCR for a known translocation like BCR-ABL. But for those who don't have translocation that you can measure quantitatively, you have to go use this ASO PCR, looking at immunoglobulin gene rearrangements or T-cell receptor gene rearrangements. This is pioneered mainly in Europe, the Euroflow consortia. The problem with this is it's quite cumbersome and laborious and expensive. So you need a baseline sample, and you have to design patient-specific primers. You have to then analyze and validate. So you probably require one person to completely be dedicated when he evaluates the initial sample. And it's not widely available. I think only in Europe, even North America, for that matter. I don't think even in Middle East we do this very much. And the other method is by next generation sequencing. In next generation sequencing, you use consensus PCR to sequence at a very high level to get a sensitivity of 10⁻⁶ or -7. So what it means is you can detect one leukemic cell out of 1 million white cells. So clonosec is commercially offers this assay, US FDA approved for BLL myeloma and more recently for CLL. So they're an chronality test looking at the baseline sample, at immunoglobulin gene rearrangements, BDJ or VJ or T cell receptor BDG, and then follow from then on. So it has very high sensitivity and it is standardizable, universally available. If you send samples to a centralized lab, and you can pretty much use any sample, fresh, archived, lymph node, whatever, except decalcified sample. You can pretty much use most of the samples, but it is expensive. But with more and more use, the price may come down in future. So this table summarizes with different methods of MRD monitoring and their advantages, disadvantages. So in the final 5 minutes, I'll just go through brief treatment options for MRD positive ALL. So we have blinatumomab, the BiTE that's approved for ALL and MRD positivity, and of course allogeneic stem cell transplant we have as a potentially curative strategy. And inotuzumab and CAR-T are not approved in MRD setting, but are potential options. So what is blinatumomab? It's a bispecific T-cell engager that has 2 arms. One binds to CD3, other binds to CD19. So the ALL, more than 90% of the cells express this CD19. And this activates the cytotoxic T-cell and apoptosis and cell lysis. So US FDA approved for relapsed refractory ALL in 2014, and for MRD more than 0.1% for patients in CR is approved in 2018, either CR1 or CR2. So this is the data briefly from Tower trial that compared blinatumomab versus standard of care, be it FLAG, HiDAC, or methotrexate-based or clofarabine, over 405 patients. Blinatumomab median overall survival was 7.7 months versus 4 months with a hazard ratio of 0.71, and so outcomes in event-free survival as well. The response rates, including incomplete hematological recovery, is around 40% compared to 30% in the chemo arm. So you are around 15 to 20% you gain in CR rates with this regimen. And with regards to toxicity, hematological toxicity is more with chemotherapy, whereas neurotoxicity and cytokine release syndrome are more with blina, which I'll go in another slide in a bit. And this is the trial that led to approval of blina for MRD. This is a phase 2 study, patients who had at least 3 blocks of intensive chemo, that is induction and 2 consolidation. If they had MRD more than 10⁻⁻3, they would go for blinatumomab. So around 85 patients out of 116 achieved the MRD negativity after cycle 1, and their survival was 38 months. Those who did not achieve MRD negativity after cycle 1, survival was 12 months. And again, the point to note here is median overall survival for patients in greater than CR2 was 19 months. Historically, this had been very poor. So another key point to take from here is nearly 70% of the patient could go on to allogeneic stem cell transplant. And again, if they're MRD negative in cycle 1, the total overall survival is 38 months versus 12, and also relapse-free survival is 23 months versus 5 months. So these are the side effects. Majority had neurological side effects, but only 10% had greater than grade 3 or more side effects. And this is another trial that looked late-breaking abstract in ASH last year from the COG group. Patients received relapsed refractory ALL post-induction chemo. They were randomized between blinatumomab or standard chemo, and standard blinatumomab had disease-free survival of 59% versus 41% So was the overall survival, and the trial closed prematurely. Looking at these results, and all patients got into experimental arm. The grade 3 toxicity or more neurotoxicity was less than 5% in the blina arm, and nearly 70% of the patients, compared to 45 in the chemo arm, went on to allogeneic stem cell transplant. So the toxicity, CRS, so the key is use DEXA, and also if they develop toxicity grade 3, start DEXA 24 milligrams a day or for 3 days, then taper over 4 days. When resolve, start at a lower dose and escalate to 28. And if it is grade 4, consider tocilizumab and permanent discontinuation. And neurotoxicity, also similar principles, and you have to probably use anti-epileptics if there is seizure. Grade 4 toxicity, you got to stop it. And final couple of slides on inotuzumab. It's an antibody drug conjugate, directed against anti-CD22 bound to calciamycin. It's expressed in more than 90% of cells in ALL. It's an innovative study, randomized phase 3 study, over 300 patients. Inotuzumab versus standard of care, be it FLAG, RSC, mitoxantrone, or HiDAC. 81% CR rate compared to around 40% for standard chemo arm. Again, MRD rate 78% in the INO arm, and median overall survival was significant too. But if you look at this graph, the initial dip in the overall survival was due to veno-occlusive disease, but later on the graph separate quite nicely. The 2-year survival is 23% versus 10%, and even 3-year data, the results remain same. With high CR rates, MRD rates, nearly 3/4 of the patients in the INO arm went on to stem cell transplant. Finally, about the complications, yes, VOD 11%, but with hyperfractionation, I think it has come down to 6%. So use ursodeoxychol throughout. Do not give more than 1 to 2 cycles. If you are MRD negative, 1 is enough. Maintain 4 to 6 weeks gap between chemo and conditioning. Avoid hepatotoxic drugs like azoles. You use more echinocandins. Avoid using double alkylators in the conditioning regimens. Something like Flubu or TBA triple Flumel is preferred. So that concludes my talk, and this is our King Fahd Medical City. This is a new OPD building down below. On the right-hand side, our new buildings coming up, 70% construction is over. Our new cancer center will be housed, and you can see a proton therapy unit as well there. Thank you very much.
Thank you, Dr. Tailor, for an excellent talk. We will switch now to the next speaker. I would like to remind the audience to type their questions in the questions tab. So the next speaker is Dr. Ahmed Absi. He is an adult hematology consultant from King Abdulaziz Medical City in Jeddah. Dr. Absi will talk about CNS disease in ALL. Dr. Absi, the floor is yours.
Thank you, Dr. Feras. First of all, I apologize for the confusion caused. I'm covering the inpatient unit, and the service is a little busy. But very glad for the excellent talks that preceded me. I thank again the organizers. I thank Dr. Alfraih, and I thank the surveyor for their invitation. I was given the task to talk about managing CNS disease and ALL involvement in IA group. There are multiple aspects actually about this subject, and so I will try to cover all issues related to CNS disease. So general introduction, typically what we see is something like that. When we talk about IA group, I think the introduction done before by Dr. Hanbali and Dr. Tailor makes my job much easier. But it's something like that. You have an 18-year-old male patient presents with acute lymphoblastic leukemia with high cell count, and he is found to be T-cell ALL with a little high LDH. Many centers still use hyper-CVAD for treating those patients. First CSF analysis showed that that patient has an RBC of 15 RBCs per microliter. WBC count of 4 per microliter, and cytospin positive for blasts. And when we face such a patient, many questions do arise in our minds. First of all, which of the risk factors in this patient do pose a higher risk of CNS relapse in that patient? Well, things like, does his immunophenotype play a role? How about his initial CNS status? How about his presenting WBC counts? And if the regimen treated on is important. First of all, I always like and direct my fellows that when they say the patient CNS status, it's not enough to say the patient is CNS positive or CNS negative. I would like them to always categorize the patient whether or not he's CNS 1, 2, or 3 disease. CNS 1 being totally negative, CNS 3 is the overtly positive, and CNS 2 is somewhere in between. And it's always a challenge when we have a patient with presenting with high blood cell count, peripheral blast count, and it's a traumatic LP, then how do we categorize that patient? It's not enough to say that this is traumatic LP, but actually there is a formula or an algorithm called Steinherz-Blair, where depending on the RBC and the WBC count present in the CSF, we do categorize that patient as either being CNS2 or CNS3. CNS prophylaxis was shown early on in the treatment of ALL algorithm of being of utmost importance. Initially, when ALL was first discovered to be very sensitive to rounds of different chemotherapeutic agents, it was also very apparent that unless those patients received intrathecal chemotherapy, that they have a high relapse rate in their CNS. There is a famous paper published in 1980, which actually was innovative when they started introducing initially the methotrexate in the CSF. And by applying IT methotrexate in that study, the 3-year relapse rate dropped significantly. Now, just to close this issue before I continue with my presentation, when we talk about hyper-CVAD, in the initial publications, they did look into the risk of CNS relapse, and that relapse correlated with 2 factors, the LDH and the proliferative index, what they call the proliferative index. They have found that the number of ITs received based on the risk status, for patients being high risk, they would need around 16, intermediate 8, and low risk only 4. Now, just to make this clear, 4 ITs in the treatment schema of ALL is definitely not enough. Now, why was it enough in hyper-CVAD? Now, that's not because hyper-CVAD is a good regimen, but that's because the majority of patients will relapse systemically. So if we have a high systemic relapse, that definitely will cover up a high risk of CNS relapse. Now, just to be fair, that study was mostly hyper-CVAD in adult patients rather than in AYA group. So why do we focus on a CNS and acute lymphoblastic leukemia? As I said before, in older studies, 50% of patients had a CNS relapse was observed without administration of IT. That risk in pediatric studies, as well as in AYA groups, has decreased to less than 5% in intensive modern type chemotherapy. CNS relapses may now represent as high as 30 to 40% of the first relapses, particularly in the low and intermediate risk ALLs. Now, that's not to say that 30 to 40% of the low and intermediate risk ALS will relapse, but to say that of the patients who will relapse, which is less than 10%, 30 to 40% will relapse in the CNS. This is decreased by multiple modalities, as we will see later. So when we say CNS disease, what are we talking about? Well, we are talking about one of 3 scenarios. Either ALL cells directly affecting the meninges, directly invading the nerve roots or directly invading the brain itself. So what are the mechanisms of introduction of the blast into the CNS? The leukemic cells can migrate from the skull marrow into the subarachnoid spaces via the bridging veins and enter into the cerebrospinal fluid. They can enter through the chorioid plexus. They can directly infiltrate the leptomeninges via osseous lesions of the skull, and we all of us had some patients presenting in such a manner. They also can invade cerebral parenchyma via the brain capillaries, and also they can grow along the nerve roots and invade the subarachnoid spaces. Now, very rarely in ALL, multiple solid central nervous system tumors are present and composed solely of leukemic cells. And finally, the leukemic cells can enter the CNS via local CNS hemorrhage when the circulating blood contains blasts, particularly in situation where leukostasis is described. Similar scenario would be direct introduction of the leukemic cells into the CSF in the first lumbar puncture, especially if it was traumatic. So there are three blood-brain barriers that need to be breached for leukemic cells to be involving the CSF, either the BBB or what we call BLMB or the BCFB. All what I've mentioned is totally mechanical scenarios, but that seems to be not the only explanation. Recently, there was some light shed about some factors related to the leukemic blast itself, as well as to the person affected with the leukemia. Work done from Duke University has shown that ALL cells in the circulation are unable to breach the BBB normally. They migrate into the CNS along the vessels that pass directly between the vertebral or the calvarial bone marrow and the subarachnoid spaces. How do they do that? The basement membrane of these bridging vessels is enriched with laminin, which is known to coordinate pathfinding of neuronal progenitor cells into the CNS. The laminin receptor alpha-6 integrin is expressed in most cases of ALL, and mice with ALL xenografts were treated with either PI3 kappa delta inhibitor, which decreases this association between the alpha-6 integrin, will decrease the CNS involvement by leukemic blasts. So that's something to look for in the future. So how do we diagnose initial CNS leukemia? Initial clinical signs they are categorized either due to increased intracranial pressure, like headaches, vomiting, papilledema, lethargy, seizures, or coma, visual disturbances like diplopia, blurred vision, blindness, or photophobia, CNS palsies, and mostly we're talking about the 7th and the 6th nerve palsy, and then other stuff like myelopathy, auditory abnormalities, vertigo, ataxia, and so forth. It's very important to note that isolated cerebral palsies are taken as CNS3 disease by multiple groups, the COG, St. Jude, AOTC, and the French group. Radiological signs of CNS involvement include abnormal MRI appearance of the subarachnoid space on the pre-contrast imaging, and abnormal meningeal enhancement in the cisterns or along the pile surface of the brain or the spinal cord. And this is again in the groups is taken as an evidence of CNS positive disease. But the ultimate diagnosis is ideally made through the direct examination of the CSF. But to do that, we really need to meet some conditions. We need to have an experienced physician, appropriate sedation, especially if a young patient. Platelet count has to be more than 50,000, or some people would say more than 100,000. And we have to use the smallest needle possible in order to decrease the leak of CSF and prevent post-puncture headache. and the patient has to be in a special position. After we obtain our sample, we either can do CSF cytomorphology, which is the gold standard, but again, this is really linked to the technique. What's the amount of available CSF, simple or double cytocentrifusion, use of medium, and so forth. And finally, definitely the experience of the cytopathologist. Flow cytometry has been a very important addition to the diagnosis of CNS involvement. There was an old study published in 2007 which showed that if we apply flow cytometry and compare it to cytomorphology, around 40% more of patients with CNS involvement will be picked up. So who are the children and adolescents at risk of initial CNS involvement? All cooperative groups reported 2 to 3% similar incidence of CNS3 disease. The mean number, nevertheless, does not reflect the heterogeneity of the disease. Children with standard risk include B lineage ALL having the lowest incidence, infants and patients with T-cell ALL having the highest incidence, and some B lineage ALL with poor risk cytogenetics are also associated with higher incidence of CNS3 disease. In the pediatric groups, this is the agreed upon risk groups for subsequent CNS involvement. Infants, Philadelphia chromosome, and hypodiploidy. I've collected all the studies that looked at univariant factors that is associated with subsequent CNS relapse, both in adults and AYA groups. This include, obviously, positive CNS3 at initial diagnosis, traumatic lumbar puncture with blast after cytospin, CNS2 plus minus hyperleukocytosis, again T-cell ALL, translocation 119, infants with translocation 411, Philadelphia positive, hypodiploidy, and some less important factors. So distribution of the CSF involvement and traumatic LP at diagnosis in selected studies. Again, traumatic LP was present in multiple studies. So how do we prevent CNS relapse? In the old studies, cranial irradiation was applied for all patients. But in subsequent studies, omission of prophylactic cranial therapy in childhood and adolescence ALL was shown to be feasible. Multiple studies have looked into that. The most important, I'll jump through this directly, that was published by Dr. Pugh in the New England Journal of Medicine, which directly compared two arms, one applying total cranial irradiation and the other intensive intrathecal chemotherapy alone. There was no difference in any CNS relapse or isolated CNS relapse occurrence, and the overall survival and event-free survival looked pretty similar. So intrathecal chemotherapy, 10% of the dose injected after the lumbar puncture reaches the lateral ventricles, and a successful CNS prophylaxis is achieved in the vast majority of patients. Now, you will find multiple variations between protocol. First of all, when is the first IT done? Ideally, many protocols have insisted in doing this on the first day of starting chemotherapy. Although a recent study has shown that delaying the first IT until day 7 may not affect the outcome. Then, what are the agents used? Cytarabine versus methotrexate. And are we talking about single versus triple? Also, a recent study has been conducted in patients with high risk of CNS relapse and compared both triple to single, and there was no additive benefit from triple IT. Finally, the total number of ITs. All IA protocols apply somewhere between 12 to a total of 25 ITs. In our protocol, for instance, we apply anywhere between 22 to 25. And these variations are partly linked to three other factors. First of all, the treatment applied. Is there high-dose methotrexate, and is there radiation? So systemic chemotherapy plays a major role in preventing CNS relapse. We are talking specifically about the intensity of the treatment, high-dose methotrexate, high-dose cytarabine, dexamethasone versus prednisone, thiopurines, and the optimal administration of L-asparginase, and the dasatinib and ALL Philadelphia chromosome. So when we talk about the intensity of therapy, the CCG 105 was the first randomized study to document the importance of systemic treatment in the prevention of CNS relapse. In that trial, for intermediate risk patients less than 10 years of age, IT methotrexate with intensified systemic regimen provided a CNS prophylaxis comparable to that provided by cranial radiotherapy. And high-dose methotrexate, believe it or not, all studies, including a major meta-analysis, has shown that the benefit of high-dose methotrexate is mainly directed in preventing systemic relapse rather than decreasing the subsequent CNS relapse. Despite that, the current 5-gram dose used in many groups is suggested to result in consistently cytotoxic concentration in the CSF more than 1 micromolar. An adequate exposure to methotrexate more than 36 hours before the beginning of the rescue by folinic acid is mandatory, as well as keeping this rescue to the minimum. And I think this is very important. Any regimen that does not apply such a high dose, plus that uses early folinic acid, will jeopardize these chances. Dexamethasone versus prednisone, the superiority of Dexa, particularly in terms of CNS relapse, depends on the dose during the induction. There are multiple studies, one from the UK, one from the IOC group, and finally a Japanese group. The Japanese, both initial trials showed benefit in Dexa over prednisone in decreasing subsequent CNS relapse, but a Japanese group which used a lower dose Dexa and a higher dose prednisone did not elect that difference. Finally, the L-asparginase depletion also affects subsequent CNS relapse. Both two studies, the EORTC and Dana-Farber, both which compared Erwinia to E. coli, had shown that Erwinia has a higher risk of subsequent CNS relapses, and this mostly in the non-irradiated patients. This probably has to do with the shorter half of Erwinia resulting in a less asparginase depletion. From this, we conclude that continuous L-asparginase depletion will decrease the subsequent risk of CNS relapse. We apply a pediatric inspired protocol for our group until age 40, and this is our protocol, including a high-dose methotrexate arm. Just jump to the results. The cumulative incidence of relapse in our protocol over 5 years is 22.1%, 13 isolated bone marrow relapse, and 7 isolated CNS relapse, bringing the risk of isolated CNS relapse in our protocol at 5 years at 6%, which is comparable to pediatric results. How do we treat initial CNS involvement or CNS relapse? As general rules, this is what I will mention. As CNS relapses are rare and first-line treatments are evolving, no gold standard exists. A recent study from the UCAL MRC group reviewing the outcomes of more than 5,000 patients has shown a marked trend towards a decrease in combined relapses with a progressive shift towards later relapses, more than 30 months. CNS relapses in the UK MRC studies thus present 18% of all relapses and are very early relapses. The main points to be considered when tailoring the treatment of a child with CNS relapse are the length of first remission, less than 18 or more than 18. Yes.
If you can finish in 1 minute.
Yeah, okay, I'll finish in 2 minutes. The immunophenotyping, the characteristics of CNS relapse, and the presence of minimal residual disease. So the general principles in children is to delay the cranial or craniospinal irradiation for at least 6 to 12 months in order to allow initial intensification of systemic chemotherapy, which leads to second event-free survival of 70 to 80% with patients with isolated CNS relapse. And the second rule is to reduce as much as possible the dose of radiation. In adults, obviously, similar rules do apply, but the irradiation in adults will most likely be left in combination with a conditioning regimen as part of allogeneic stem cell transplant, since we see in adults no adult or IA group will be salvaged with chemotherapy alone. Finally, there are 3 novel modalities: inotuzumab ozogamicin, blinatumomab, and CAR T-cell. Inotuzumab really has no CNS activity. Patients with CNS disease were allowed in receiving ITs, and there was no difference in toxicity profile. But blinatumomab, though, the bite itself does not cross the blood-brain barrier. Patients with CNS positive disease was mostly excluded from the trial. And this is because grade 3 to 4 neurotoxicity was seen in 7 to 9% of 2 phase 3 approval trials. We all know what the blinatumomab side effects, but I'll just say MD Anderson has published their experience with giving blinatumomab to patients with CNS positive disease. And they utilized ITs during this therapy. And the results was presented in 2018 ASH. They showed grade 3 or higher blinatumomab related CNS toxicity was noted in only 2 patients, 18%, and 83%, 5 of the 6 patients, 83% with active CNS disease at time of blinatumomab treatment cleared their cerebrospinal fluid. I would still be cautious to combine blinatumomab with ITs, because if the patient develops neurotoxicity, we won't be able to differentiate if it's coming from the IT or the blinatumomab. I would prefer to clear the CSF first with ITs and systemic chemotherapy, and to follow it with blinatumomab without combination IT. Finally, CAR T-cell has been shown in mouse models to be present in the CSF and of the T-cells expansion in the CSF. This subsequently was implemented in the Chinese presented their published actually their data in 2020 of 110 patients treated with an anti-CD19 CAR T-cell therapy. Out of those patients, 23 had extramedullary disease and 17 had CNS leukemia. Patients with extramedullary disease or CNS leukemia did not show any increased grade 3 to 4 CRS or neurotoxicity, but they did show inferior CR rate and inferior MRD negativity. The CR rate in patients with CNL leukemia was 76% compared to 95% with CSF negative, and the MRD rate was lower as well. This is important because in that trial, patients with CR had a better chance of overall and leukemia-free survival, and MRD as well. And that's also to mention that regardless, those patients still will need to go to allogeneic, because patients who did not undergo allogeneic still subsequently relapsed in less than 1 year. But CAR T-cell therapy definitely does present an important addition to the treatment schema where with patients with either a systemic relapse or extramedullary relapse, including CNS relapses. And I will stop here. Thank you very much.
Thank you, Dr. Absi. Excellent review. Now we will move to open discussion, and this is the time for questions. So if you have questions, kindly type it in the questions tab. If you'd like to use the audio, we can open the audio.
I have a question. Can I ask it?
Yes, please, Riad.
A question to the panel about MRD testing and Blina. You know, we are using a lot of Blina now for MRD positive and in relapse refractory in transition to allo transplant. And sometimes to save time and expedite the process, we tend to do a bone marrow while the patient is on the last days of Blina infusion. How does that affect the MRD testing?
Dr. Tailor wants to comment on that.
Blinatumomab, I think it should, if you are testing, as far as I know, in the later stages of treatment, once the patient is in remission, I think it should not affect too much. But if you can use other modalities same time, I think that's also better. But I am personally not very sure of exact interference while you're giving blina.
Dr. Amr, Dr. Absi, any input?
Yes.
Hello. What I noticed from a few patients that we've been doing the bone marrows after blina, of course, there is loss of CD19 in the bone marrow, and many times I noticed the pathologist has difficulty in calling it MRD negative. I don't know if because of the changes that that we see after the use of blina, but that's what I noticed. Many times we have to discuss with the pathologist, like back and forth, to have them say for sure that this is MRD negative after blina. But that was my experience.
Dr. Absi, any experience? You're muted, Dr. Absi. You're muted.
Sorry. Yeah, so I agree. I think it's challenging. We have to remember that the trial itself used NGS to determine MRD negativity. With flow cytometry, in that setting, I'm not aware of any data. But to keep in mind, you know, the half-life of blinatumomab is so short. And I would imagine if you know, you do the bone marrow within days, let's say 3 or 5 days after the stoppage of blinatumomab, I don't think there should be any effect technically on the results. We started doing NGS in our hospital, and we just actually started last month, and we're correlating this with flow cytometry. So that's part of the group of patients that we will be looking into.
Okay, thank you. I have a question also to the Dr. Tailor. So regarding high quality MRD test, so how can we ensure that we have a high quality MRD test? I mean, frequently I see a report of flow cytometry, a regular flow cytometry done and interpreted as an MRD.
Yeah, I think it's important. We need to talk to the flow cytometry hematopathologist and exactly discuss to get a sensitivity of 10⁻⁻⁴, which we're aiming for. I think all the studies, at least we target of 0.01, less than 0.01. So they need to look at least 200,000 to 500,000 events. So if you want to increase that sensitivity, you need to increase even more to 1 million or 2 million, even up to 5 million. So hematopathologists, I think we want them to exactly mention, is it less than 0.01% or what it is, because that's our target, at least 0.01%.
Thank you. So there is a question to the panelists. How many total IT do you give in your protocol? So Dr. Amr?
Our protocol, we go from 24 to 29 ITs during the whole phases of therapy.
Dr. Absi or Dr. Tailor?
Yeah, we give between 22 to 25, but we do apply 5 grams of methotrexate. So, but that's our regimen, yes.
Yeah, we follow the COG protocol, and it has approximately around 24 IT throughout the course of treatment.
Okay, thank you so much. So I think we will we have 5 minutes I think behind, so we will move to the next talk. Will be given by Dr. Riad Elfakih. Dr. Riad Elfakih is an adult hematology consultant with several publications in ALL, and he will share with us some practical approaches in ALL management. Dr. Riad?
So I chose 2 cases. I have 15 minutes allocated for this talk. First, let me thank SSBD and Servier for this invitation. And I chose 2 practical cases that I saw on the inpatient service. The first one is an 18 years old presenting with shortness of breath with near normal counts, I would say, not completely normal, a little bit low platelets, around 125. Now, she got a chest X-ray, and that showed some widening of the mediastinum and pleural effusion. That was followed by a CT scan that showed above and below diaphragm lymph nodes, and a lymph node biopsy revealed this phenotype, CD45 positive, 3-7 TDD positive, and CD79 positive. It was negative for all the others, and that was followed when we found out that it looks like blast cells leukemia with the setting of low platelets. We did a bone marrow biopsy, and in the bone marrow biopsy it was hypercellular with 35% blast, and the morphology was not easy. We've had conflicting data from the lymph node and the bone marrow, and at some point it was called mixed phenotype B and T cell ALL, because in the bone marrow CD19 was positive. So eventually we did molecular testing for immunoglobulin and the T cell receptor, and the T cell receptor came back positive, the immunoglobulin negative. So it was a T cell ALL rather than mixed phenotype B and T. The fish showed nullosomy TP16 in 30% of nuclei. The karyotype was normal. So basically we have a CNS negative T cell ALL, and as you know, we use the IA protocol, a pediatric protocol, and day 14 we did a marrow and actually showed worsening of the disease, which was surprising for us. And at the same time, the patient developed tachycardia with shortness of breath, and workup showed a right atrial thrombus. It was line-associated thrombus. So at that time, we were discussing salvage for this patient. We were starting to adopt R3 protocol, which is a pediatric protocol for salvage that has asparaginase in it. So here we have a patient who is progressing at day 14 and has a right atrial thrombus, and a discussion was made in the group about if we can use asparaginase, should we use it, is she resistant or not? And this is a very practical question that comes along at some points. So as you know, asparaginase is an enzyme present in a number of natural sources. The clinically used asparaginase is from E. coli and Erwinia. And as you know, asparaginase degrades asparagine into ammonia and aspartic acid. So basically how it works, it deprives the leukemia cells from asparagine, exogenous asparagine, and in that way the leukemia cells cannot build DNA and RNA during cell replication and cannot replicate. Now the leukemia cells don't have the ability to synthesize asparagine. The normal cells do have some ability, and additionally the normal cells are not replicating as fast as the leukemia cells, so they don't need a lot of asparaginase. And basically this is how it works on leukemia cells. So as you know, it's a foreign substance, foreign protein from bacteria, so hypersensitivity can occur, and that hypersensitivity can be of type 1 hypersensitivity. And type 1 hypersensitivity is when the antigen is presented by the T helper cells to the B cells, and the B cells are simulated to produce IgE antibodies, and these IgE antibodies go and sit on the surface of mast cells or basophils, and then once a re-exposure happens, these cells are already sensitized and they will release the storage granules and lead to anaphylactic reaction. So you don't expect anaphylaxis from the first injection. It can happen, but you have to be careful with future injections. What I meant to say, if you don't develop anaphylaxis on the first shot, doesn't give you a guarantee. And it is a protein synthesis inhibitor, as we said, because it depletes the cells from asparagine. So patients tend to have protein, enzyme, and hormone deficiency and side effects from that. On the other hand, it is a very important drug because it's not myelosuppressive or very little myelosuppressive, not cytotoxic, and doesn't cause the problems of chemo like hair loss, mucositis, and all these side effects. So this is just a quick summary of the hypersensitivity reactions. These can be simple injection site or urticaria all the way to anaphylaxis, and also the protein synthesis inhibition side effects like decrease in the coagulation factor can lead to bleeding or thrombosis. Decrease in the insulin leads to hyperglycemia, albumin, edema, alteration in liver function test and liver enzymes, hyperbilirubinemia, fatty liver due to the hyperlipidemia. Pancreatitis can happen from the ammonia, and neurologic dysfunction can happen as well. So this is the summary. And as in our patient, we have a patient who is day 14 progressing, and she has a right atrial thrombus. So coagulopathy is usually due to an imbalance in the coagulation factors from depletion. And the majority of the asparaginase associated thrombotic events would happen during induction therapy. And that's because probably the patient has other risk factors like indwelling venous catheter, the use of steroids in all these protocols, and the leukemia itself, because it's still active, we're still inducing the patient. There are no standard or reliable parameters to predict or prevent coagulopathy while using asparaginase. Now, we all use, we do the IC panel, we follow fibrinogen, we replace with FFP and the cryo, but these are controversial. They're not set in stone. Now, so back to our case, what does the major societies recommend in case of thrombosis while on asparaginase? So it's an open recommendation, actually, open to interpretation, because that's what they recommend. Withhold asparaginase in the case of clinically significant thrombosis. What's clinically significant? I don't know. Each one can interpret it the way he wants. And restart asparaginase under anticoagulation therapy once symptoms resolve. So back to our patient, we said she's probably not getting this much benefit from asparaginase as she's day 14 and blasts are increasing, and additionally she had a right atrial thrombus, which can be life-threatening. So she was started on anticoagulation, and we opted to go for a salvage without asparaginase. We did not use R3, we used FA followed by a transplant when she achieved remission. So that's the first case. And we'll move to the second case, also another practical case on the inpatient. 52 years old male, newly diagnosed B-cell ALL. Okay, so past medical, diabetes, hypertension, coronary artery disease. And the question here, can we use asparaginase? Now, just to mention, our AYA protocol, as Dr. Hanbali presented, we started with the AYA protocol up to the age of 30. And then once we found that the toxicity is okay, we expanded the use up to the age of 39. So currently it goes up to the age of 39 in our institution. And here we have a 52 years old patient. And the question again is it safe to use asparaginase? So back to the side effects, just to mention that in older patients, they may be at higher risk of complication. So we see here the hypersensitivity is around 30% in adults as compared to 24% in peds. And this hypersensitivity is reduced if you use the pegylated form of asparaginase to around 3 to 14%. So significant decrease, okay? But this is PEG asparaginase, and PEG asparaginase, the way it's different from the regular asparaginase is it stays in the body for around 3 weeks, okay? The regular asparaginase is has a very short life. But again, these are the rates of hypersensitivity versus this one. And the prediction of hypersensitivity is unreliable, so you cannot give a shot and predict. Pre-medications can decrease the clinical signs of hypersensitivity, but at the same time, you can mask the fact that this patient has some hypersensitivity and may be developing antibodies to asparaginase, and that way you lose the efficacy of asparaginase. Now, just to mention that IM versus IV, with the IM regular asparaginase, you have lower hypersensitivity than IV, and the opposite is true for PEG aspar. Now, this is again the half-life, as you see here, very short for the regular forms, and this is for the pegylated, around a week. And this is why when you use PEG, you use 1 dose, and when you use the regular forms, you use more frequently at a shorter interval. So again, the pegylated reduce the hypersensitivity, prolongs interval between dosing, and 1 dose of PEG asparaginase can replace 6 to 9 doses of native asparaginase. So again, you have the side effect associated with protein synthesis inhibition, and these are not affected by the formulation, whether you use PEG asparaginase or regular, and not affected by switching to another type like Erwinia and E. coli. And all these side effects of the protein synthesis inhibition are exaggerated by age. So the symptoms can be severe enough to warrant permanent discontinuation. Part of it because these patients has a lot of comorbidities and have low organ reserve. So with any small complication, they can deteriorate. Acute pancreatitis happen in 2 to 5% of the patient, and it tends to happen a little bit higher in the older population. It can progress to a severe form. Routine monitoring of lipase and amylase did not show any benefit. However, symptomatic pancreatitis is what affects your decision, and it is recommended with any clinically significant pancreatitis not to reuse asparaginase, as it has a high recurrence rate described in one publication. Up to 63% will have recurrence of the pancreatitis. As far as treatment, you treat it as the same pancreatitis. Hepatotoxicity tends to be higher in older patients because these are on other drugs. They have comorbidities. They might start therapy with a fatty liver. And when you get hepatic toxicities, you get hepatic dysfunction, treatment delays. So it affects the overall treatment plan for your patient. Now, it is recommended to withhold asparaginase in any patient with grade 3 or 4 elevation of LFTs, which is more than 5 times above the upper limit of normal. And again, hyperglycemia can happen, and older patients tend to have comorbidities like diabetes, and plus you're using steroids. And the hyperglycemia happens usually because of decreased serum insulin from decreased production of insulin or decreased expression of insulin receptors. Dyslipidemia can happen because the lipid-carrying proteins are not produced enough, and this may be a little bit less with Erwinia as compared to E. coli. Neurologic symptoms also can happen, and these can be affected by age, definitely, as you all know. Hypoalbuminemia can cause third fluid, third spacing, and anastarca. So this case was discussed again, and the idea was to put him in remission and transplant. So decision was to start IA protocol, and because of the concern of toxicity with the PEG asparaginase and the prolonged exposure, we decided to use the short-acting asparaginase because it can go out of the system quickly if anything happens, rather than staying in the body and causing problems for a long while and delaying the treatment of the patient. So PEG aspar was substituted with native aspar, and sure enough, the patient develops problems from regular asparaginase. So shortly after starting therapy with asparaginase, the patient develops abdominal pain, nausea, and vomiting, and this is the spike of lipase. So we had to stop, and thankfully, it did not progress to a hemorrhagic or necrotic form. The levels went down with the stopping of the medication, and the patient improved and continued therapy in remission, planning transplant soon. With that, I will finish and happy to take any questions.
Thank you. Thank you, Riad, for an excellent presentation. Let me see a question. So there is a question. So for how long you shall continue a blinatumomab if patient did not achieve MRD negativity after one cycle? Maybe Dr. Tailor?
Yeah. I think in the study, the BLAST trial, nearly 70 to 80% of the patients achieved MRD negative after cycle 1. And even if you look at the COG trial recently presented up to 3 cycles. So I think I would, in patients who do not receive transplant, we can go even up to 6 cycles. But I think for transplant, I would say up to 2 or 3 cycles. And if no MRD, if it's still MRD positive, I think it's worth considering other agents such as inotuzumab, which has got very high MRD rates as well, almost 80%, because the outcomes are extremely good, better if patient is in an MRD negative state before he goes to transplant.
Thank you. Question to Riad. So there is a question in the last case you presented. Why did you insist in giving IA protocol?
So this case was discussed extensively because the patient had some cardiac comorbidities, and the dose of doxorubicin on the IA protocol is fractionated rather than on the adult protocols we use, which is a big dose. So that was the main factor that pushed us to use an asparaginase-based protocol with fractionated doxorubicin, hoping to put the patient in remission and then transplanting him.
Can I make some comment?
Yeah, please.
Yeah.
Sure.
With regards to PEG-ASPAR, I would just like to make 2-3 comments, practical points. I think, as Riad told, there is no data about FFP or antithrombin or other agents. But if the patient has thrombosis, and if you are experiencing heparin resistance, they have a depletion of antithrombin. I think in that situation, one can give antithrombin free to overcome heparin resistance. And secondly, with regards to pancreatitis, I think we should have a objective evidence of pancreatitis, like hemorrhagic pancreatitis or real, because for biochemical pancreatitis, I think we should not deprive the patients of PEG-asparaginase or asparaginase. So grade 3 or 4, what we're talking about. With regards to allergic reactions, I think if you look at the UCAL data, the reactions, hypersensitivity discontinuation was very low. UCAL 2003, over 3,000 patients, it was something like 0.02%. And the reason for that is they use PEG-aspar on the backbone of 4 days of steroids. So I think we should try to use PEG-aspar in such a way that the patient is on steroids, not just 100 milligram hydrocortisone that day is enough. And with regards to what was the last point? So I forgot. So I think these are some of the practical points sometimes and helpful in managing, and also the dose of pegaspar. I think an adult patient, especially over 40, in our institute, we are using up to the age of 50, the pediatric protocol, and we've been using from 2013, probably earlier than some of the other institutes. Pegaspar, I think we have to be careful, slightly older and with risk factors. At the dose of pegaspar 1,000 to 1,500 units, you almost completely deplete the asparagine. So you got to be careful, or sometimes consider capping at 3,750 rather than giving the standard dose of 2,500 units per meter square. Yeah. Thank you.
Okay, all good points, and I agree. So we all replace the factors when we have coagulopathy or disturbance in the biochemical test. But again, this is not backed up by studies, but practically and theoretically, this is what we should do, and this is what we all do. The hydrocortisone with pegaspar, also I think all the institutions are doing what you're doing, Dr. Tailor. We start steroid pre-phase, and then with the induction, then we introduce the pegaspar. But again, the concern I raised is whether we are masking the antibody development, because it does decrease the clinical hypersensitivity, and at the same time, a patient might be developing hypersensitivity without clinical signs, so you would not notice this, but the patient had developed antibodies, and his benefit from pegaspar is not there anymore. So these are just points to keep in mind. The pancreatitis, definitely you would not deprive a patient from pegaspar benefit with mild or biochemical. And as I showed, following lipase and amylase is useless. Better to follow the clinical picture, as Dr. Tailor said.
Just with regards to antibodies, if I just say one point, if you look at the UCAL 2003 data, they were using steroids for 4 days before they give pegaspar. Again, you need to do asparagine levels. I don't think we have that here. To know whether you have neutralizing antibodies. But when they looked at the data, the good news is the emergence of antibodies was very, very less than 0.5%. So I think, and this was over 3,000 patients. So hopefully this should not affect, increase the risk of antibodies.
Thank you both, Dr. Riad and Dr. Tailor. A question to Dr. Absi. How would you overcome the challenges of thrombocytopenia in delivering IT?
Well, I mean, besides the transfusion, I don't think much can be done. Obviously, if you have the ability to, especially in the younger population, and the protocols that do administer up to 25 ITs, definitely having an OMIA and would help. Now, but still, the same problem do still arise with OMIA. If you look at recommendations, you can go with a little platelet count to access the OMIA itself, but to put the OMIA and for the several days after the initial insertion of OMIA, you still have to maintain higher platelet count, approaching almost to 100,000. Now, the recent trial that have shown delaying the initial IT 7 days after the initial presentation, I think helped. We do apply steroids pre-treatment until we get all the cytogenetics and molecular studies out. And most of those patients, after a week or 10 days of steroids, their platelets really start showing some response. We rarely have issues, to tell you the truth. Patients are either platelet transfusion responsive or starts recovering their platelets soon enough to allow us to administer the rest of ITs during the initial induction.
Do you stick to a platelet threshold of 50 for IT?
Yeah, IT we go with 50. We go with 50, and we never seen complication. I know some people recommend higher, but we go with 50, and we've never seen a complication.
I have to say, yes, please.
Once you finish.
Okay, so in King Faisal, sometimes actually we accept 30 for special situations for IT. However, I mean, the general recommendation is 50. Yes, someone has a question or comment?
Yeah. It's just a comment on the Dr. Absi presented the MD Anderson trial about the BLINA in CNS positive patients. So it's interesting, but one should be careful. Now, BLINA causes CNS toxicity, and the way it causes CNS toxicity sometimes is by inducing brain edema and increased intracranial pressure. So they did use ITs at MD Anderson, but maybe we have to look carefully into that trial and see if they did CT scans or anything to see if the patient has any signs of increased intracranial pressure before using IT while on a BLINA.
Yeah, I agree. I think we have to be careful and then interpreting this. I think, the point is that if I have a patient who I have no other option other than using blinatumomab, I probably would use it. Initially, we were very cautious not to do so, but I would still recommend, though, not to combine ITs with the blinatumomab, because the point is, if the patient develops neurotoxicity, we're going to end up stopping both, unfortunately, and because we won't be able to know what caused what. I would recommend to go to hold of CNS disease with aggressive ITs and then use the blinatumomab.
Okay, so the last question we have would be for Dr. Amr Hanbali. How would you manage ALL who is recovering from COVID-19? What's your recommendation and the best approach? I mean, when to start treatment? Would you modify the treatment for someone who's recovering from COVID?
Okay, so on a practical point, I had a few patients who were on the protocol who also got the COVID-19. So basically, of course, during the acute infection, no chemotherapy, no steroid will be given to the patient till full recovery of the viral illness. And once the patient is discharged home, okay, no symptoms whatsoever related to the virus, and he passed the duration that's put by the the WHO or the local infection control committees, then the patient can go back and resume. And actually, they just went back and resumed the full treatment without any problems thereafter. So as long as they're cleared from infection control and they have no symptoms, basically we can resume full treatment.
Thank you, Amr. I think because of the time, I think we have to conclude. So I would thank all the speakers for the great presentation. I would like to thank the audience for making it very interactive and hopefully fruitful and educational for everyone. Special thanks for survey team for supporting this event as well as helping in organizing it. Thank you, everyone.
Thank you. Appreciate it. Thank you all.
Thank you.